All right, today we are diving deep into psoriatic arthritis. This is one of those really complex inflammatory diseases that goes way beyond just the skin. And we're going to be drilling down into a very specific treatment pathway and a drug that hits it in a pretty unique way, brodalumab.
So that's the big question, right? This is the central challenge for doctors, and of course for the patients living with it. Psoriatic arthritis, or PsA, isn't simple. It's not just one thing. It's a war being fought all over your body on multiple fronts. So how on earth do you fight back effectively?
Okay, here's how we're going to tackle this. We'll start with the big picture, looking at the whole family of diseases that PsA belongs to. Then we'll zoom right in on PsA itself. From there, we'll explore the key inflammatory pathway that's driving all the trouble. And finally, we'll get into the nitty-gritty of the clinical trials for brodalumab to see exactly how it performed. To really get what psoriatic arthritis is all about, we actually need to zoom out first. You have to understand that it doesn't exist in a vacuum. It's part of a much larger family of diseases. And that family is called spondyloarthritis, or SPA for short. Think of it as a group of related conditions that all have this similar pattern of inflammation, and they really love to target the spine and other joints. And psoriatic arthritis? Yep, it's one of the most prominent members of this family.
All right, so now that we've set the stage, let's bring our main character out into the spotlight, psoriatic arthritis. You know, PsA is a really tough opponent. It's a chronic condition where your own immune system basically goes haywire and starts attacking not just your joints, but also these really specific spots called entheses. That's where tendons and ligaments connect to your bones. And of course, like the name says, it's almost always tied to the skin condition psoriasis. If you leave it untreated, it can cause some serious permanent damage and really impact someone's life. Now, here's something I find fascinating, the timing of it all. For most folks, the skin problems from psoriasis show up first. But the time between that skin diagnosis and when the arthritis actually kicks in, well, that can be a huge variable. We're talking years, sometimes even decades. And it turns out that time gap really, really matters. So check this out. Research is showing us that this timing is actually linked to different genetic flags. So patients who get arthritis pretty quickly, in under 9 years, we'll call them the early group, they're more likely to have a gene called HLA-B/27. And unfortunately, they often end up with more aggressive joint disease down the road. But then you have the late group. They're more likely to have a different gene, HLA-C/06, and they often have a higher BMI and worse skin problems to begin with. It really suggests there are different biological roads that all lead to PsA. So what's the engine behind all this inflammation? Let's peel back the layers and get down to the molecular level to see how today's treatments are designed to step in and stop it.
Okay, one of the main culprits in PsA is this family of signaling proteins called interleukin-17, or just IL-17. You can think of these cytokines as tiny messengers of chaos that scream at the immune system to go on the attack, kicking off all the inflammation that causes the nasty symptoms of PsA. So here's how it all goes down. First, these different IL-17 cytokines, A, F, C, and others, get released into the system. They're on a mission, seeking out a very specific docking station on our cells called the IL-17 receptor A. Once they bind to that receptor, it's like flipping a master switch on, setting off this huge inflammatory chain reaction that leads directly to PsA symptoms. And this is where things get really clever. See, a lot of drugs target just one of those cytokines, like IL-17A, but brodalumab's strategy is different. It goes after the receptor itself, that common docking station. By blocking the IL-17 receptor A, it stops not just one, but a whole bunch of different IL-17 cytokines from delivering their inflammatory messages. It's kind of like blocking the front door of a building instead of trying to catch every single person trying to run inside. So that's the theory. But how does this unique mechanism actually perform in the real world? For that, we're going to turn to the two massive phase 3 studies that put it to the test, AMVision 1 and AMVision 2. Here's the basic setup. These were really well-designed, high-quality trials. We're talking almost 1,000 patients with active PsA who weren't getting enough relief from other treatments. They compared 2 different doses of brodalumab against a placebo. And the main goal, what they were really looking for, was something called an ACR20 response by week 16. That's just a standard way of measuring if there's at least a 20% improvement in key things like joint pain and swelling. This is it, the million-dollar question for any arthritis drug, right? Did it actually work? Did it calm down the inflammation in the joints better than a sugar pill? And the answer was a huge, resounding yes. I mean, just look at the data here. It's crystal clear. Only about 21% of the patients on placebo hit that 20% improvement goal. But look at the brodalumab groups. Almost half of those patients did. That's more than double the response of the placebo. In the world of clinical trials, that is a clear, decisive win.
But like we said, PSA isn't just about achy joints. For a treatment to be a real game changer, it has to work on all the different ways this disease shows up. So let's look at the final verdict. How did it do on the skin and on those other painful symptoms like dactylitis and enthesitis? And, of course, was it safe?
Well, its effect on the skin was, wow, just as impressive. The goal here was something called PASI 100, which means 100% skin clearance. No plaques, nothing. Look at the placebo group. Only about 4% got there, but in the 210 milligram brodalumab group, over 40% of patients had their skin become completely clear by week 16. The difference is just staggering. The drug also went to work on dactylitis, that really painful sausage digit swelling you can get in your fingers or toes. Get this, more than half of the patients on the higher dose saw their dactylitis completely go away. Compare that to less than a quarter in the placebo group. And it's pretty much the same story with enthesitis, that inflammation where tendons connect to bone. Once again, you see a much, much higher number of patients on brodalumab getting complete resolution compared to placebo. It was clearly hitting all these key targets of PSA. But what about safety? That's always the critical question, isn't it? Well, the data here was actually very reassuring. If you look at the overall rate of any side effect, it was practically identical between the brodalumab and placebo groups. Same story for serious side effects and infection rates, all very similar. Basically, no new or scary safety problems popped up in these trials. Now, to put all this into context, let's see how brodalumab stacks up against other major IL-17 drugs. And I have to stress this. These were not head-to-head trials, so you can't directly compare them. The patient groups and study designs were different. But what this does show you is that brodalumab's response rate of almost 48% is very strong and fits right in there with the other powerful options in its class. It is absolutely a major player. And that really brings us to our final thought. What the AM-Vision trials proved is that blocking this shared IL-17 receptor is a seriously effective way to treat PSA. And that raises a really exciting question for the future. Could this wider blockade, hitting multiple inflammatory signals at once, give us some unique advantages in treating the entire complicated spectrum of psoriatic disease? Only time and more research will tell. Thanks for tuning in to this deep dive.